Welcome to a quality improvement project on the reduction of colon surgical site infections. This project was based at Adventist Health Central Valley Network. Adventist Health is a nonprofit healthcare system. It is a network of 4 rural health hospitals in Central California. It is a Seventh-day Adventist Christian-based hospital whose mission is living God's love by inspiring health, wholeness, and hope. Values are to be loved, be a force for good, be a mission owner, be welcoming, be curious, and brilliant. Whose vision is to transform health experience to their communities by improving physical, mental, and spiritual health. My preceptor for this practicum is the Network Director of Quality and Risk, Candace Belson. Needs assessment. It was during a meeting with Premier Incorporated that I and my preceptor decided on my project. Premier is a leading healthcare collaborative that has launched Quest. Quest is a program to help systems connect with peers, evidence-based practice, and data. While reviewing data with Quest, it was discovered that the hospital's colon surgical site infection rates were higher than the national average. During this call, Quest provided recommendations to improve these rates. Upon completion of this call, it was decided upon with my preceptor to collaborate with operating room leadership to use some of these recommendations to improve surgical site infection rates. The project was to reduce colon surgical site infection rates. The hospitals are mandated reporters to multiple agencies, and these agencies use this data to create benchmarks. Benchmarking is a measurement of healthcare organization services against other national healthcare organizations and provides comparisons for best practice and evidence-based practice. The Centers for Medicare and Medicaid implement quality initiatives to assure quality healthcare. The benchmarks used in this presentation are collected by CMS in various quality initiatives that include quality improvement, pay for reporting, public reporting. In response to the organization's high SSI rates to the national benchmark, this project will review trends, prioritize measures, identify objectives, plan for improvement, and monitoring. Benchmark rates. The graph attached demonstrates the organization's year-to-date standardized infection ratio is way above the national CMS benchmark average. The year-to-date procedures of this organization were 66. The year-to-date infections were 3, which sets their standardized infection rate at 1.45, where the benchmark is only 0.08, as evidence above the national average. The outcome for this project is to achieve top decile in patient safety for the organization by achieving and maintaining a standardized infection rate below the national average for colon SSIs. Goals were set to obtain this outcome. Short-term goal is to assist in determining where the organization is in the process of SSI reduction. This includes performing a gap analysis with the key stakeholders within the first quarter of the clinical year. The long-term goal is to develop a performance improvement plan to decrease colon surgical site infection rates by eliminating gaps in the best care bundle by the second quarter of the clinical year. To obtain the outcome and goals, we set upon a plan, do, study, act for the evaluation of this process. PDSA is a method to test change by going through the prescribed 4 steps, breaking down tasks, evaluating the outcome, and improving on testing. As you can see, the planning stage included to evaluate colon SSI rates for the organization, perform a gap analysis to evaluate the use of the Enhanced Recovery After Colon Surgery Best Practice Bundle, and to develop a surgery readiness form for standardized ERAS process. The do was to educate operating room on best practice measures, ensure the operating room staff have all necessary supplies, educate and implement the surgery readiness form. In study, we evaluate the effectiveness of the surgery readiness form, ensure standardization, provide feedback to OR staff regarding ERAS process, and continuing surveillance of colon surgical site infections to monitor data related to the SIR and benchmarks. Finally, under ACT, we review the ERAS process and make changes as necessary. Evaluate, educate, and continue the performance improvement project. This slide demonstrates the work that was done on the Enhanced Recovery After Colon Surgery form. What we did was we implemented a surgery readiness form that involved short stay, intraoperative, and post-op procedures. The highlighted areas shows the new or improved objectives: antibiotic stewardship, completion of CHG bathing, completed nasal decolonization were part of the short stay measures. In intraoperative measures, we continued with antibiotic stewardship, clean closure technique, closing of the skin and fascia, and then a clean change of gown and gloves for dirty procedures. In the PACU, we continued with appropriate antibiotic stewardship. The goal of this form is to have communication across each area of operating room, evaluate the effectiveness on preventing surgical site infections. Prophylactic guidelines. The pharmacy were huge stakeholders in this process. While working on the process improvement project regarding surgery can be a daunting process, surgical processes have integral procedures that involve multiple departments and stakeholders. Since the prevention of surgical site infections involves every aspect of care, including preparation, intraoperative, and postoperative care, stakeholders are imperative. As you can see in this slide, the pharmacy was involved with stakeholders through the prophylactic guidelines, where we implemented badge buddies that reviewed GI cases, dosing, and redosing as necessary. The next stakeholder involved was our nursing staff. All preoperative patients who are inpatient or being admitted postoperatively should have a nasal decolonization and a CHG bath done prior to surgery. ERAS guidelines includes pre-op, bathing, and nasal decolonization. These stakeholders had initiative including education, nursing, and materials management all had to be involved to ensure that we had appropriate products, knew how to use the products, and were using them correctly. The next stakeholder involvement, including our operating staff. Another imperative for the ERAS is to improve the process of contaminated gown and glove change to the implementation of a clean closure. In the instance when a sterile gown and glove person becomes contaminated, any contaminated items will be removed and the sterile gown or glove person will have their gloves removed by a non-sterile person using aseptic technique. New gloves donned upon assisted gloving technique. Implementing a clean closure involves intraoperative staff and sterile processing stakeholders. In a study using clean closure technique, part of the bundle approach that the overall SSI rates were dropped. Including this element was imperative for intraoperative staff members and sterile processing to ensure they had appropriate supplies and education to move forward with the assisted gloving and gown changing. Once a quality improvement project has been implemented, the next step and on is to maintain sustainability. Each person involved in the colon SSI reduction process holds a significant role in leading and ensuring completion for each component in their specific area. The project will require additional monitoring and re-education and updates in processes as needed. The surgery readiness form with all updated components has been initiated. The next step will be to enter the form into a Microsoft Forms document so the organization will be able to use this data for improvements. The data from this form and continued surveillance of the colon surgeries will be done in collaboration with the OR educator, OR manager, and surgical lead nurses. The control plan will include performing 5 real-time audits to monitor success. And on glove change, nasal decolonization, CHG baths, and the usage of the surgical readiness form will be done a week for 3 months or until the process is continued. Working together with a goal to report a decrease in colon surgical site infection rates to the Surgical and Quality Committee will ensure sustainability. QSEN competencies and professional goals. Throughout this performance improvement project, implementing outcomes and goals, I have learned many things, including the use of SMART goals, being a change agent, time management, and definitely informatics skills to prepare nurses to have the knowledge, skills, and attitudes necessary to improve quality and safety. The Quality and Safety Education for Nurses developed 6 graduate competencies. Out of these 6 competencies, patient-centered care, teamwork, collaboration, evidence-based practice, quality improvement, safety, and informatics. Integrating all of 6 of these components into my Practicum project has been imperative for success. Based on my skills, strengths, and weaknesses, I have used specific, measurable, achievable, relatable, time-bound, SMART goals to assist me in becoming a change agent. Working with my preceptor to develop my time management and informatics skills and reaching my personal goals. Lessons learned. Quality improvement is a framework used to systematically improve care by seeking standardization process and structure to reduce variation, achieve predictable results, and improve outcomes for patients. Healthcare systems and organizations working through the project and preceptorship has taught me the importance of being a change agent. A change agent acts as a catalyst for change and plays a critical role in analyzing risk involved, weighing the pros and cons, and are the consultant, trainer, and researcher. Quality improvement is not one and done process. It requires thoughtful methodology. Using a process like PDSA assists in focusing on continued reinforcement of change. Learning more about organizational change and what it takes to provide safe, quality care has been invaluable. Thank you for allowing me to share with you my quality improvement project on the reduction of surgical site colon infections. Below are my listed references. Thank you.